Assalamu alaikum. Inshallah, today we will talk about knee exam. Consent is important as usual. I am Ahmed Ra'attar, orthopedic surgeon. Can I take some information from you and examine you? Personal history, name, age, occupation, location, complaint. 4 main complaint. The main complaint and associated complaints. Pain, usually is 4 for all systems. Pain, instability, deformity, stiffness. Pain, if it is main complaint, you will analyze as usual, and the associated one you will analyze also. So you will ask about instability. Instability could be simply due to pain and due to true mechanical symptoms like giving way and locking. Giving way could be rotatory, in case mostly it will be ACL. Rotatory instability means that the patient, when he is out of your office and cutting a corner, he will feel that his knee is unstable, or while anteriorly, while downward or upward in the stair. It could be simply due to weakness of the quadriceps. A big difference between both. This is BT, could be a simple management for him. Or the second one for the mechanical symptoms is locking. While flexion or while extending his knee, he feels that something is blocking his movement. He do a tricky movement. He is the only person who knows this tricky movement until unlocking. This is a true locking. Third one is the deformity, either varus or valgus, and analyze this complaint. But most importantly also swelling. If this swelling occur at the same time or in the next day. At the same time, usually it is ACL injury. In the next day, usually not ACL. Stiffness. Again, analyze stiffness. Is in flexion or extension? Is it post-surgery trauma? Surgery mostly is ACL reconstruction. So main complaints for one of them and analyze the 3. Then neurovascular complaint, constitutional complaint, and other joints, cervical, spine, and hand, to exclude rheumatoid. All these complaints, how they affect his life, either in pain and function. If he has a twisting injury during playing, can he continue his playing, or he has to take a rest? If he continue playing, mostly it is not a serious injury or like ACL, but if he can continue, he could be some simple injury. What about walking, standing, sitting up and down stairs? His pain making him sleep well, or he couldn't sleep comfortably. Then what you did since that time, what is radiology, investigation, medical, or even surgical management. Then going to physical exam as usual, not to forget gait. Gait is the starting. The usual stampa for us is symmetrical smooth transition between swing and stance phase with adequate step length. In the knee, there is 2 gait abnormalities mostly important. Antalgic gait, which is short stance phase, and lateral thrust. For example, knee genovarum with ligamentous laxity. This is exaggerated deformity in the stance phase. Also, you will comment on if he has splints or walker or crutches and so on. Then going to inspection. Inspection, as usual, front side back. As usual, skin contour deformity. Still the patient is standing in front of you. You will comment to the scar, and contour meaning muscle wasting. From the front is quadriceps. Then deformity, coronal deformity, but you have to make his patella is facing forward. Genovarum, genovalgum, and from the side, please turn to your side, either any side, and compare to the other side. Sagittal deformity like recurvatum, procurvatum, skin if any scars, and contour hamstring and calf muscle, and also from the back the same. Then ask the patient to sit at the edge of the bed. If you have already a deformity, after sitting on the bed, and you will observe his deformity. For example, if he has genovarum, and when he sit there is no genovarum, so this is mostly coming from the femur, and if it is little or decrease, mostly combined from the femur and the tibia. Then asking your patient to extend his knee to see the patellar tracking. J sign means that there is lateral subluxation of the patella. Then putting your hand to feel crepitus, and when you will observe his extension degree while he extending his knee to see if there is any extension lag or due to muscle weakness, for example. Then please be supine on the bed, starting from the extended position to the flexed position. Again, this is my protocol. You can do your own protocol, but don't forget any item. You're starting from the extended position. You can observe his extension and make it active then passive. You will examine effusion. It could be examined as a viva case alone. Still, they are favor in effusion examination. Then collateral, and sometimes Q angle. So 4 types of items you have in extended position, then the flex the knee, and 5 type of examination as you will see. We will go on. During extension, now he is supine on the couch, and he is extended. You will see passively and compare to the other side the extension degree. Sometimes they want you to examine to make the degree exactly with geniometer. Your landmark is one of the limb of the geniometer is along the lateral malleolus, the center of the geniometer lateral epicondyle of the femur, and one in line of GT. You will compare to the other side, the same with flexion. Sometimes you have a flexion contraction like this. Contraction, flexion contraction mean that there is no active or passive in the contralateral side. If it is flexion contraction, there is no active or passive extension. So if he tell you, and you observe something like this, tell you what is the extension degree, tell your examiner that you couldn't examine his extension because he is in flexion contraction. Second item is effusion, wipe test, ballottement and patellar tab. This is wipe test. You starting by wiping the medial side until this furrow, normal furrow appear. Then wipe the lateral side. If it is coming some bulging here, there is a mild type of effusion. Then ballottement for moderate. You will squeeze the suprapatellar pouch with one hand, and the other one you will press from the lateral side, pushing the medial side, and pushing from the medial side, pressing from the medial side, push the thumb out the lateral side. This is ballottement in the horizontal plane. In massive effusion, you will have also ballottement, but in vertical degree. Again, squeeze the suprapatellar pouch, accumulate the fluids in this area, then elevate the patella the fluid will elevate the patella by pressing through your index. Your patella will go downward. This is called a tap test or patella ballottement test in the vertical direction. Collateral exam, still you are in extended position. I prefer to do a collateral exam on the edge of the couch. If you do a collateral examination, either medial or lateral, varus and valgus stress test on the edge, it is more easier than to elevate the knee like this, and more accurate, because you will put your thumb and index at the edge of the joint line, so you will feel the opening of the joint line and compared to the other side, and also you will avoid rotation of the patella while stressing medially or lateral to avoid exaggerated or underestimation of the deformity. So examine the collateral, medial and lateral at the edge of the bed to avoid rotation of the patella, and also to keep your spine sound. Usual in all your body, if you examine in 30 degree, you will isolate what you examine. So if you did the examination, for example, varus test in 30 degree, you're stressing the lateral collateral ligament. If you make it an extension, you will make the posterior capsule sharing in resistance of the varus test. The reverse in valgus stress test in 30 degree, stress the medial collateral. If you make it in full extension, you will stress it in you will stress the medial collateral and posterior capsule. So lastly, the Q angle. Actually, Q angle is horribly inaccurate if you did it with the use of geniometer. But some Viva examiner ask you how to measure the Q angle with the geniometer. You will, after feeling the anterior superior iliac spine, you will put the index of the patient himself. Then you feel the center of the patella, put the center of your geniometer. The other limb is with the tibial tuberosity. This angle is measured normally about 12 degree. Q angle couldn't be measured in flexion. It is one of the components of examination of the knee in extension. Why? If you do a flexion, this is unlocking mechanism, so internal rotation occur in the tibia, so the tuberosity coming internally, so the Q angle is decreased. Palpation. Now you are starting a flexion. The 5 items in the flexion. Palpation. You can do palpation whatever you want, starting from up to down, but be systemic. For me, I am starting from tibial tuberosity, patellar tendon, then the joint line, medial joint line, going to epicondyle, medial epicondyle, then surface of the upper surface of the patella, quadriceps tendon, other side, lateral side, then lateral side of the epicondyle of the femur, lateral joint line and girdis tubercle, and bis and serenius. This is the points which I feel in flexion. Then going to ACL in flexion. Before starting examination of ACL, you have to be sure that you didn't have a BCL. If you're starting ACL examination in a BCL position, so you will have a false positive data. If you have a BCL through the observed through the SAC sign, you have to make the tibia in its normal position, then starting ACL exam. So you will put your palm of the hand on both tuberosity and compare them, and by visual, by your eyes. So then starting by sag sign, if you have a BCL, if you have a posterior displaced tibia in relation to the femur, you have to make it in the normal position, then starting ACL exam. So first is sag sign, then anterior drawer. The examiner sit on the foot. The knee is in 90 degree. His index is feeling and relaxing the hamstring. Then his thumbs on both hands on the joint line. Normally the tibia is seated about 5 millimeter in front of the femoral condyle. So if more than this compared to the other side is ACL. But you have to feel and exclude hamstring tightness, and this is 90 degree. More accurately is lachman test. Lachman test, please, if she is a female, don't sit on her foot. You can use your elbow here to avoid the sitting on it. This is more accurate, but if she is female, you have to put your elbow. It's very painful, but use your elbow. Don't sit on her foot. Lachman test. Lachman test, you make it the same. Anterior drawer, you anterior draw the tibia, but in 30 degree. Why 30 degree? There is a secondary function of the posterior horn of the medial meniscus. This secondary function prevents the anterior translation of the tibia in relation to the femur. This is done in about 90 degree. So there is a secondary function of the menisci to prevent the anterior translation of the tibia in relation to, and this secondary means that when the primary function fail, when the ACL fail, in 30 degree you make the posterior condyle of the femur away from the posterior horn medial meniscus. So its fake effect is away, so it is more accurate. One, and also you are relaxing the hamstring, effect of the hamstring. Some thigh is very large, so I personally use my leg, I put my thigh below his thigh. But again, if she is female, you can do this. You have to put a pillow here. Then anterior, you doing anterior drawer. You feel translation and end point. Translation, as usually, I inform you, it is about 5 millimeter. This is the normal anterior step off of the tibia in relation to the femur. If it is translated more than this, in comparison to the other side, this could be ACL. Also the end point. You have firm and soft end point. Firm end point which is normal, like you stretching your clothes suddenly. This is the sense of firm end point. If it is yield with you, this is soft end point. Again, don't depend on your power here. You can put your thigh or a pillow here to make you relax and feel good. This is the door stopper effect of the posterior horn medial meniscus. Then the pivot shift test. Pivot shift means that the pivot point is shifted. Normally it is the center of the knee, around the ACL. Pivot shift, when the ACL is disrupted, it is shifted to the medial collateral. When you put the patient foot between your axilla, in your axilla, automatically you do valgus and the internal rotation. Valgus to pivot on the medial collateral. So if the medial collateral is torn, you couldn't do this test. Internal rotation, this is make the lateral tibial plateau translated anterior, and you feel with your thumb this translation, and you're starting from extended position. When you're doing a flexion, you will feel a bob of reduction of lateral tibial plateau. This is because when you are in extended position, the iliotibial band act as an extensor. When you do a flexion, it acts as a flexor, reducing the lateral tibial plateau. This is pivot shift test, and mostly this is done intraoperatively after anesthesia. Actually, lachman test is more accurate, and the translation combined with endpoint is one of the most important guide for deciding what to do for this patient. Posterior drawer is the reverse of all. Then lastly, McMurray test. McMurray test is starting from flexion. Pivot shift starting from extension, and the McMurray starting from flexion. If you're doing internal rotation, you are exposing, making the lateral plateau more prominent, lateral meniscus more prominent. Together with valgus cyst, you are squeezing this more prominent plateau menisci, lateral oriented meniscus. Then extending. If she feel pain or he feel pain or a clicking, this is for lateral. The reverse is for medial. Extension with, yes, varus moment. Then prone position. This is all was in supine position, either in extended position, then in flexion position. Then prone, you are inspecting the popliteal fossa, then palpating the joint line posteriorly. Then two tests, ably compression test, ably compression distraction test, and dial test. Ably compression distraction test is for the menisci. You compress if she feel, if the patient, if your patient feel pain, so the menisci could be some abnormalities in the menisci, but and if with distraction this pain, it increase the accuracy of this test. Dial test again in 30-degree. This is isolation of posterolateral corner. You do in the prone position. This test can be supine. I inform you about my system. I do dial test in the prone position in 30-degree. This is isolation for posterolateral corner if there is any asymmetry more than 10-degree external rotation. In 90-degree, this is BCL plus posterolateral corner. This is dial test in prone position. Lastly, back to the supine position, do patellofemoral test. Be careful that patellofemoral examination could be a separate entity away from the knee examination. Could be done only patellar test, patellofemoral examination. By inspection, we are at the edge of the bed. We observing the patellar tract to exclude J sign. Then palpation of the undersurface of the patella, medial facet and the lateral facet. Then tilt translation and apprehension. Tilt mean that by your thumb you are trying to tilt, elevate the lateral edge of the, while the index is depressing. Should open about 20-degree. If couldn't open, this is called that lateral retinaculum is tight. Translation, approximately half of the patella could be translated either medially or laterally. If it is not or exaggerated, tightness or laxity. Then the lastly patellar apprehension test is very painful. So for that reason, we make patellofemoral examination as the last to examine. All these tests are painful. So, and especially apprehension test, you are trying to push the patella, translate the patella laterally from extended position, then trying to reduce it through the flexion of the knee. This is squeezing of the patella and is very painful. This is the patellofemoral apprehension test. Thank you.